And we are live. Excellent. Welcome, everybody, to live stream with me, Sarah Merritt from Lifestream Health Center. We're in Bowie, Maryland. We're here to revolutionize acute and chronic pain management so that your care is caring and accessible, patient-centric, and evidence-based. We want you to live life better. And so if you're interested in educating yourself to make practical changes to better manage pain and your overall health, then you're in the right place. Pain is inevitable, but suffering is not. So I'm particularly excited to introduce my friend and colleague, Dr. Karen Kaufman, who's here today to talk about mast cell activation syndrome. Karen, I'd love to have you introduce yourself to our audience.
Well, thank you so much for having me here. This is just such a pleasure to be a part of this with you. And anyhow, without further ado, my name is Karen Kaufman, and I am the founder and CEO of Kaufman Allergy, Asthma, and Immunology, which is a practice in Vienna, Virginia, so not too far away from Bowie in the greater Washington, D.C. area. And I help children and adults who have allergies and recurrent infections to live better lives with fewer symptoms, on less medications, and enjoy the quality of life that they deserve.
Awesome. And so what kind of conditions are commonly treated by a medical doctor like yourself who is an allergist and immunologist?
It's a very wide range of conditions, actually. And so there's a lot of overlap in my specialty with a lot of other specialties as well. So not only do we manage patients who have all different types of allergies, like environmental allergies, food and stinging insect allergies, but we manage lots of skin conditions, including chronic hives and eczema, swelling of the skin, asthma, and some other immunologic respiratory disorders, primary immune deficiencies, and of course, mast cell disorders, which, are just part of the array of some of the great things that we do over here.
Awesome. And how do patients know if they need to see an allergist immunologist? I mean, is it something, I guess maybe a two-part question, is it something that might be recommended to them by another doctor, or might they refer themselves if they suffer from these conditions? How does that work?
Yeah, definitely both. And I would say a lot of doctors, especially primary care, who, may only have a very short period of time with patients to do kind of routine health maintenance, or dealing with other chronic medical conditions. A lot of times, the management of symptoms that are often associated with allergy are kind of pushed to the back burner. So sometimes that stuff doesn't get as well addressed as maybe patients would like, because, while you're not going to have any major detriment from, let's say, allergic rhinitis, it really impacts your quality of life and has so much fallout on how patients feel and how they live. And people deserve to feel well. So it's both. I would say sometimes physicians who have patients who, maybe even have recurrent infections. And, the question is, I've been giving this patient antibiotics over and over and over again, but why are they getting sick so much? That allows us an opportunity to really dig in and find the answers to some of those questions. But patients also self-refer all the time, right? Like this is like the classic adult. I've had these symptoms my whole life and I've never really dealt with it, and they're getting worse and worse. And now I'm just sick of it. And so I'd like to see an allergist. Great, I'm here, so it's a lot of both.
Well, and one thing I actually didn't realize until recently when we were talking about it was that concept of, if somebody is getting sick over and over, who do you see who helps diagnose that problem? Because there are specific immune deficiencies, and while they are rare, they're not maybe as rare as we like to think they are.
Right. They're only rare if you're not looking for them.
Yeah. Just, oh, you're sick, and you just leave it at that, right? That's simpler. But what if there's an answer? What if there's something specific to find?
Yeah, it happens all the time. And so my threshold, I know this isn't really the topic we have today, but my threshold of who needs their immune system evaluated, really it's anybody who has too many infections that are too severe, or infections with unusual features. All of that stuff is odd, right? Like someone says, well, I had an infection, I required like 3 courses of antibiotics to get it to go away. I'm like, that's weird, why? Right. So those are the individuals that I would say, let's do a good workup and see. And a lot of times we will find that there are things that are either easily fixable with booster vaccination, or we may identify underlying immune deficiencies that are treatable and manageable. And so, you can't manage it if you don't look for it and you don't find it.
That's right. Yeah, and it's always exciting to find an answer or something that's more treatable.
Sure. And even like, I'll give you a great example. I did a follow-up today just to go over immune labs with a mom of a 3-year-old who I see who literally is always sick. I mean, this poor child, And so, we're on the path to discovering what the cause of this is. And the answer to it is going to be, no matter what it is, whether we fix a problem or we treat a problem, is going to be substantially improved quality of life, where she's going to have a period of wellness that she just hasn't experienced at 3,
That's
so it's
awesome.
Really awesome. Yeah, it's really awesome.
Well, I think I do want to definitely make sure we have time to dive in on mast cell disorders, because I know from our conversations that we both treat patients who have mast cell disorders, mast cell activation syndrome, and I would love to have you tell us more about it. As a physician, I know some about it, but I think I personally am also excited to hear about your expertise in this area. How did you get interested in working in this space, and do all allergists understand this disorder?
It's such a good question. So, of course, mast cells are immune cells. And so the very complex immune system falls under my specialty. So, while all allergist immunologists can deal with immune disorders, sometimes there are things that we just don't as commonly see. And so, even with immune deficiencies, for example, so the level of comfort of any one doctor is always, I think, proportional to their experience. And so, you can read about things in a book, but once you start seeing it, it's a different story. So, I would say, I don't know that I would say I have a specific interest in any one condition, like in mast cell disorders over any other problem that I manage in my clinic. But I do have an interest in helping people. And when people call my office and say, would you see someone with this problem? The answer is always going to be yes. Sure, I'll be happy to come and have you, get evaluated, and I'll do my best to help you. And if I don't know everything I need to know, then I'm open and willing to learn it, so that way I can help. So I think it's just the attitude of being a helper that really, is what makes you open to becoming an expert in things that you weren't an expert in, or learning more about things that you knew less about, right? And the goal is always to do that, to help somebody to get better, to live better. Then, that's worth the time to spend.
That's awesome. And so what is a mast cell anyway? It's some type of immune cell. Where are they found?
Yeah, so mast cells are immune cells, and they hold a ton of different immune granules inside of them. And part of their job is to protect us in the interface between our body and the environment. And so they're designed to help protect us from dangerous stuff. And where we may encounter those dangerous things may be in parts of our body that interfaces with the environment. So the skin, the respiratory tract, the gastrointestinal tract, in our connective tissue, in our blood, right? So these are areas, right? If you get a wound or a cut or something, right, we need to have these cells there to be able to help us. And they really regulate part of our immune response to different triggers.
And so in some respect, they're kind of like a first line of defense. Is that correct?
Yeah. And they're not, they're not meant to be problematic for us, but they can be, particularly in the setting of allergy. So, when we think about an allergic response, when we think about environmental allergens or food allergens or stinging insect allergens, what happens is our allergic antibodies will engage with these cells and contribute to them releasing some of these immune granules. And then the symptoms that we experience are symptoms that come from the interface of these immune granules with receptors elsewhere in our body and in the localized tissue, and inflammation develops and all sorts of stuff. And so some of the symptoms, many of the symptoms that we experience are due to these mast cells and their mediators.
Mm-hmm. And so is there a definition for mast cell activation how do we define that, and maybe how do we diagnose it?
Yeah. So, I mean, I think the first thing before we even talk about mast cell, disorders, which really when we think about mast cell disorders, we think about mast cell activation syndrome, which is really kind of a functional disorder where the mast cells are degranulating and we don't really know why, right? It's spontaneous. They're not being triggered by something that we understand. We have proliferative problems of mast cells, and this includes clonal disorders like mastocytosis. But even in the normal functioning mast cell, our mast cells, as they degranulate, will contribute to symptoms. So when we think about that in the setting of allergy, a term that we use is anaphylaxis, which is the name of a multiple body system reaction. And so what happens, and when you think about these places where we find mast cells, this is where we find symptoms. So skin symptoms may include things like hives or swelling or itching or flushing. We may have respiratory symptoms like coughing or chest tightness, labored breathing, or noisy breathing due to obstruction like wheezing or even maybe stridor. We can have a lot of GI symptoms. So this may be cramping or bloating or pain, vomiting, diarrhea in the setting of an acute response. And cardiovascular symptoms can also be involved relating to a drop in blood pressure. So people get lightheaded, they get dizzy, they pass out, they have syncope. And so in the setting of an allergic response, we've got a trigger and then we've got this reaction. And so when we talk about diagnosing mast cell functional disorders, we're talking about a lot of these same symptoms of anaphylaxis, but without a reason, without having that allergic trigger present. And so these patients experience symptoms, like this on a regular basis. So in order to diagnose mast cell activation syndrome, you have to be able to distinguish the difference between mast cells degranulating for other reasons and mast cells degranulating without a great reason. So differentiating this from other problems is part of our diagnostic criteria. But otherwise, patients need to have clinical symptoms that are suggestive. So again, symptoms of anaphylaxis. And it may not occur as a sudden event like we think about anaphylaxis in the setting of allergy, but it's almost like all of those same symptoms that happen even more regularly. And those patients also need to get better on associated treatment. So really is a clinical diagnosis. There are some laboratory values that we can follow, including something called tryptase, which is a mediator that comes out of the cell in the setting of one of these mast cell degranulatory responses. And the tryptase level will elevate in that acute setting for a very short period of time, but it may not elevate necessarily above the reference range of the lab. So it can be really confusing to people, but it'll elevate from that patient's baseline. And then, there's a couple of things that can be checked in like a 24-hour urine collection, although from a practicality standpoint, I really don't rely on tests to say, do you have it or do you not have it? I mean, really it's, does your tryptase go up in the setting of an acute response? Are you having symptoms and do you get better? So it's kind of a clinical diagnosis.
Yes. And how are you going to be able to measure that tryptase in an acute response? I mean, might you challenge a patient, or would you instruct a patient to go around a trigger? Or I guess if MCAS maybe doesn't require a trigger though, right?
Correct. Yeah. So I wouldn't, right? So I would just, for example, like if someone has, a stinging insect allergy, I wouldn't put them through a sting challenge or have someone eat a food allergen. We don't do that. We want to strictly avoid like known triggers, but if someone has an event, not recommended, correct. But if someone is having an event and ends up in the emergency department, we sometimes will ask patients, sometimes I'll even, when we used to have prescription pads, I'd give them a little prescription that said, please ask to draw a tryptase within 6 hours of the onset. I've almost never received results of any of that testing being ordered, but that would be the setting of where we would do it, would be in the setting of an acute response in the emergency room.
Very good.
I don't know that they want to be responsible for the results of it. So they want to know, what's the acute answer for an acute problem.
Sure. And certainly in the ER, the answer is, do you get better with epi, and then there's more epinephrine given, right? I think.
Right.
Very good. Well, tell me more about the mast cells. So So for a patient that has mast cell activation syndrome, are there treatments, or, what is the management of this condition? If we talked a little bit about it being a clinical diagnosis
Yeah.
I guess if you want to speak any more on the diagnoses, and then what would be the treatments for it?
Yeah. So, I mean, part of the diagnosis is getting better on appropriate therapy. So, when we manage this, what we're really managing are the mediators that come out of these cells. And so we really start our management with antihistamines. So histamine is one of our big problem children here. So responsible for a lot of skin and gut symptoms. And so we utilize antihistamines that block two different receptors called H1 and H2. And these include medicines that many people have, over the counter, things that they use to treat, common symptoms. And this includes we try to use more of our second generation H1 antihistamines like cetirizine or fexofenadine or loratadine. And these are medicines that people will often use for the management of symptoms of seasonal allergy, rhinitis symptoms. We also use H2 antihistamines like famotidine, which is something that people may use as an over-the-counter management for acid reflux or gastritis. And so by blocking some of these receptors, we do see substantial improvement in skin symptoms of hives, swelling, itching, and even some of our gut symptoms relating to bloating, cramping, nausea, reflux symptoms, things like that. And so that's really the starting point of management. Often we'll use, or people may feel more inclined to use, our first generation antihistamines like diphenhydramine, which is what we think about as Benadryl, or branded Benadryl, which is a really fast acting antihistamine, but for long-term management, it's fast on and it's fast off. So it doesn't give a lot of long-term control. So I think the role of our first generation antihistamines is more for what we call breakthrough symptoms, which is, right, we want to get this baseline level of control. And this is the same holds true, I think, in pain management, right? You want to get your baseline level of control, and then you want to have something that you can use as add-on therapy for, acute worsening of symptoms or something like that. So antihistamines is definitely the first place to start.
Very good. And then you're going to be assessing if the patient gets improvement with those therapies, right? That's part of the criteria.
Exactly. And then there's a lot of potential add-on therapies as well. And so sometimes we'll use medications that block glucotrienes, like montelukast as an example. Sometimes we'll use medicines that are known to stabilize mast cells, like we use a lot of cromolyn for the gastrointestinal tract nasal symptoms. And sometimes we'll use ketotifen, which is an antihistamine and mast cell stabilizer combination, which we can get here in the US OTC as an eye drop. But sometimes what we'll do is have it compounded as an oral therapy, and patients find that gives them some better systemic stabilization of mast cells. And sometimes we even use biologic therapies like omalizumab, which has been around for a long time, almost maybe 20 years or so at this point, which is a biologic therapy that binds our IgE antibodies. So it's used for management of other problems like severe allergic asthma, chronic hives. We've been using that for the last almost decade for chronic hives, now nasal polyps. So there's a lot of uses of the medicine, but it really, we find that it does help stabilize mast cells and reduce degranulation for a lot of folks, even though it's an off-label use specifically for mast cell activation syndrome. But that is something that may help.
Yeah, that's pretty interesting. Dr. Celine Lee put a comment. She is asking, how useful is the gene test for mast cell activation?
I don't know that we have an unknown genetic linkage to say, do you have it? Yes or no? Gosh, wouldn't that be great if there was a single test where you can, where you can just do a test of I have it or I don't have it. So I don't know that we really know the genetics of it at this point, although, certainly we tend to see mast cell problems associated with some other conditions. Certainly for mastocytosis, which is a different problem, right? It's a clonal disorder of mast cells. We will see that based upon a mutation of c-KIT, which is a growth factor that's in our bone marrow that will increase the proliferation of these progenitor cells. And so, sometimes, for individuals, let's say, who may have an elevated tryptase level at baseline that's quite high, I usually will collaborate with hematologists to say, look, does this patient need a bone marrow biopsy for further diagnostics? Of course, we don't like to bone marrow everybody, but when there are some other factors that are pointing that direction, right, as we're trying to distinguish what's the difference between this and potentially other problems, looking for a c-KIT mutation is maybe helpful.
Very good. And that would be what's in the clonal. And by clonal, we mean a bunch of mast cells that are exactly the same, correct?
Correct.
Sorry, I've got a siren going by here. I'm going to mute myself. Very good. And mast cell activation syndrome doesn't have that clonal characteristic. That's not part of it. Correct. It's more of a tendency to degranulate, a tendency for the mast cells to activate. And then we're going to diagnose it also based on response to treatment.
Correct.
I can say just anecdotally that I've had patients tell me that they just overall feel a lot better. So I have a segment of patients in my population with Ehlers-Danlos syndrome. They may have chronic joint pain related to this, and mast cell activation syndrome seems to be a commonly occurring diagnosis in these patients. And what I have definitely heard anecdotally over some years of caring for such patients is that they feel so much better if they get their mast cell better managed. Tell me about that.
Well, I think everybody feels better when their problems are better managed.
Right.
But there is a lot of overlap of mast cell functional problems with other disorders, including Ehlers-Danlos. And I see a lot of patients who have, and this is the hypermobile type, so a lot of problems of pain. And so, I really value, our clinical relationship and how you're able to help my patients, because a lot of times one of the things they complain about the most is pain. And, pain is not necessarily directly tied to their mast cells, although as mast cells degranulate locally, there will be inflammation, and mast cells are present in connective tissue, which maybe is the linkage of why we see issues with hypermobility. But yeah, management of all of these all of these different syndromes that tend to overlap, and joint management with collaborative, doctors that are just helpful, help in general. Because, if I see somebody whose mast cell symptoms are great, I saw somebody yesterday, it's a great example, patient of mine who's been seeing me for a couple of years. She has a history of allergies. She's on allergy shots, has been doing great. And then, started having really bad symptoms relating to tachycardia and postural orthostatics. And when that's not controlled, it doesn't matter how well you're controlling the rest of the problems. Your whole world is upside down and it's total disarray. So it really is multidisciplinary management. But getting these patients to feel better is
right. Yeah, if it's hard to get up and walk across the room, then it's just going to be hard to do much of anything.
Correct.
And I've even told some of my EDS patients that see me, like, I feel in some respects that I serve a little bit of a primary care function, because really sometimes it's a matter of writing them referrals to other docs, to other providers, to get, other pieces, in that management puzzle handled.
Sure. And I think too, once you start to realize who in your area are the helpers for the patients that have these conditions, we tend to help a lot of the same patients, and they're just, they're just so grateful to be plugged in to a network of doctors that are really, there to listen to them and to help them. It's
absolutely.
important.
Yeah. Thank you. I've got a question on our YouTube feed. A patient who said she's been diagnosed with hypermobile EDS, MCAS, and POTS. She reacts to dyes, fillers, etc., and medications, and I've had anaphylaxis reactions. Do you feel pharmacological testing is worthwhile, and which one would be recommended?
I'm interpreting the question as like pharmacologic testing to see if there are medicines that aren't tolerated for different reasons. I actually had a patient today. We were talking about this very thing. And I think that there's a role. I mean, the problem with mast cell activation is that the mast cells are degranulating, right? So what happens is they're degranulating anyways, and we take all these medicines. So then the question is it the medicine or is it the problem, right?
Oh my gosh, yes. Oh my gosh,
Oh my
yes.
gosh, I see so many patients with a list of all of these, medications that they don't tolerate or they don't take or that end up on the allergy list. And then other doctors send patients to me like, they're allergic to everything, please figure it out. And so,
It's hard.
but some people do have a problem where they can't metabolize certain medications. So I do think that it's, there's a role for that. And if we could do testing to say, are there things you really truly shouldn't take? Like, let's do that. But then also let's manage everything else, So no, I think that's such a good thought. It's a great question.
And in my clinical experience, in terms of this question, how would we test for dyes, et cetera, right? And look, I don't do that testing, but I can say, do I have patients that, I've written on a prescription if they're getting a generic medication, no yellow dye version of whatever genetic medication or generic, excuse me. We've certainly done that for patients who find they appear to have a sensitivity. Gee, I did fine with the pill from last time and it was this generic, can we request that clinically, right? And this is kind of what we're talking about. It's just a clinical management of a symptom. Okay, clinically, I can say, I can keep asking for this particular type that appears to be okay for you. And sometimes, unfortunately, that may be the best we can do.
Well, yeah. And this happens a lot too with with fillers and things like that. So I have patients that come in and they'll say, look, like I always have this problem with corn. I cannot have corn. I cannot have corn as a filler. I cannot be anywhere near corn. I have a massive problem with corn. And it's like, okay, great. So we can do testing and say, do you have a corn allergy, right? Immediate hypersensitivity. When the answer is no, it doesn't mean that the person should then eat corn. Right. So when we talk about food intolerance,
right.
When we're talking about food intolerance,
is that an intolerance then? If we're going to accept that you have some sensitivity, that is true. You're not allergic. That doesn't invalidate the fact that you have a sensitivity.
Correct. So when we talk about food intolerances are problems that people have with things that they eat where the foods cause them to have symptoms. But the symptoms are just not mediated by our immune response sometimes. And that doesn't mean that the symptoms aren't there. A lot of times it's, components of the foods that interact with receptors in our bodies that cause symptoms. And, it's like, in the example I always use, maybe if it's your clinic where it's like, doctor, when I do this, it hurts. Well, don't do that. It's like, okay. So, right. When I eat this, I feel terrible. Well, great. Let's pick something else. So I agree with you. I don't know that there's a great answer to the question of why does that make you feel that way? But if they feel better without it, I'm happy to also write that same prescription that says, let's pick a different filler, or whatever for compounded medications as an example.
That's right. Yeah. I've definitely written a compounded diphenhydramine before for someone who's sensitive to hey, over-the-counter Benadryl.
Right.
I've had trouble with it, but can I get a compounded diphenhydramine that's very, clean, so to speak,
right.
With a filler or whatever that is known and is something that doesn't bother the person.
Absolutely.
Yeah. And it's amazing really what a difference I think for that patient with sensitivities, what a difference that appears to make, right? That tailoring a regimen, tailoring to that, I think can make such a huge difference.
Yeah. And another thing we talk about a lot in some patients who have problems of mast cell degranulation is the role of histamine in foods. And there are many foods that we eat that are naturally high in histamine. And a lot of these things are foods that go through the fermentation process. And so, they'll say, well, when I eat this stuff, I feel worse. And so, there is, and that's not the case for everybody, but there is some kind of a threshold of how much is too much, so the answer, so sometimes patients will come to see me and they're on these really strict elimination diets and that becomes problematic because they end up sometimes ultimately developing problems of micronutrient deficiency. Plus it's just really, a challenge to live a good quality of life when things are so restricted. And more often patients can find great success in, just volume reduction. So whether it's, I'm going to eat less of this item, or I'm going to have a meal that has less volume of high histamine foods, or maybe I'll have less high histamine foods in the day, so there are ways that we can kind of modify it in a real world version that's not so restrictive that that other problems will come about. So that kind of falls under the same umbrella of intolerance.
That's great. Dr. Lee has another question. She wants to know, do you see that there are more mast cell activation syndromes among people who have long COVID?
That's a good question. I think there's a lot of overlap in mast cell activation symptoms with the symptoms people experience with long COVID. Is it the same? I'm not sure. Because some of these folks with long COVID were totally fine before. And some patients who have long COVID or have symptoms that are suggestive of mast cell activation maybe had similar symptoms but more mild beforehand. So I don't know if it is exactly the same, but I will tell you that as mast cell activation syndrome is much more prevalent in the literature now than ever, I think COVID has a lot to do with that. And that's a lot of, referrals or even self-referrals too of patients of, do I have a mast cell problem because I feel these symptoms? And so what's so hard is that there's so much overlap with, a lot of these symptoms that have, they're multiple body system symptoms. Yes. And so there's a lot of other conditions that can cause these symptoms.
Yes. Well, and I think I was just going to say, I have some awareness of, a friend's daughter, patients who maybe after a viral illness or COVID develop dysautonomia that's really significant and, potentially pretty disabling. Or actually here, right at this moment in the comments, Kendra Sprouse says, I have quite a few friends who have POTS post-COVID. And I think that's that dysautonomia picture.
That's well described. Mm-hmm.
Yes. And I think, if anything, I think it's worth thinking about, how can we prevent these problems? Is there any prevention for mast cell disease? Is there anything we can do to keep ourselves insulated a bit from it?
That's a good question. When we're talking about dysfunctional cells, sometimes they can be triggered by all different types of stressors, right? And like threats to our body. So infection is something that can trigger it, or not that it's going to trigger the development of a mast cell problem, but maybe a flare of mast cell symptoms. So, certainly we want to keep ourselves healthy, keep ourselves kind of, keep the life stress-free, right?
Yeah, but wellness kind of behaviors are positive. Yeah.
Yeah.
That's super interesting, actually. I mean, and just kind of the idea is, as far as a flare of mast cell symptoms, is there a length of time that it lasts? Is it just hugely variable depending on if it's related to something? I certainly have patients who talk about being in a mast cell flare, but I don't have as big of an idea of, what does that really mean, or how long does that last?
Yeah, patients define that differently for their individual experiences. So sometimes a mast cell flare is non-IgE mediated anaphylaxis, and it's an event, and sometimes people describe, lack of control of mast cell activation over time as a flare, right? If things aren't controlled, then they're flaring. That makes sense too, So, the goal overall is going to be to achieve the best control we can get on the least amount of medications that patients need. And people do get better. I mean, they do well. This is not something that we know to have a cure, but it's manageable. It's manageable.
Yeah, I was just going to say that. Yeah, can you give us a success story to maybe like wind things up on a positive note, a success story, or something that's been positive with a mast cell patient?
Yeah, I mean, I feel like I could just think of so many success stories where, patients come back for follow-up and they're just, dramatically different than they were when they were here the first time. I saw a lady today who, had really just started very kind of beginning therapy, mostly just antihistamines. We're starting to talk about cromolyn for GI, symptom relief, but her biggest complaint today was something completely unrelated to this. And I said, well, tell me about some of the symptoms you're experiencing, relating to your mast cells. She's like, oh, those are all better, so it, it does get, and it's part of the diagnosis, right? It's got to improve on the appropriate therapy. So when we find that it just doesn't get better at all, it's the wrong problem,
Yes.
But I think some of the more important success stories that I find are the personal stories of patients who have been to every doctor. They've been told that they're too complex, that they can't see them, or they don't have time in a 20-minute appointment to even like go through their medical history or their medicine list. And they're patients that have been to the emergency room and told, well, you don't have anaphylaxis because you didn't eat something that preceded this event, and it's people who have been put off, who just want to get better. That's all they want, is to get better.
Yeah.
So to be able to lend that listening ear and to be that compassionate physician, that's some of the best part of this.
Yeah, and I think there's a real tendency historically, and maybe this is getting better, but I think there's a real tendency to write off or discount. If we don't understand it, then you don't have this, or this is made up, this is not real. If you have some symptoms that doctors can't easily explain.
Right. Actually, I had the same conversation with a patient today who had a symptom that was in her mind associated to environmental allergies. And I said, well, that's not a manifestation of environmental allergy symptoms. But I said, I'm not telling you you don't have symptoms.
Yeah, this happened.
But we need to also look at other possibilities, or think, we'll still treat your environmental allergies, but let's think about other possibilities, because I'm not going to tell you you're not experiencing that because it doesn't fit the picture.
Right.
I'm just not getting the whole thing yet.
Yeah. The synthesis of the cause and effect. Right. The clinician is going to have a different. The patient has one synthesis, and they're not wrong about the symptoms, but the synthesis of what it is or how do we fix it, might be different in the doctor's mind. I think it's an exciting space in a way, because there's a lot of progress we can make.
Yes. And actually what's interesting, and maybe this is just why I have such a large population of patients with mast cell disorders, is that patients just called my office and said, are you taking new patients? Well, yes, of course we are. And would you see somebody who has this condition? Well, of course I would. Right? Like, yes. There's no other answer than that. And so, that's how, sometimes patients find me, and it's just a gift to be able to provide that care to them. So it's great.
Oh, I just love it. I just love talking to you. And I'm so excited that you've been able to tell us all about mast cells.
Well, also, I will say that, I'm so grateful to you, because there, as I had mentioned earlier, like, patients come in and they complain a lot about pain, and I'm not the person to necessarily fix their pain, but to be able to collaborate with somebody who can, for that, I'm so grateful.
Thank you. Yeah, no, it's an honor to get to help people, and with pain management. I often really feel like if I've helped somebody in a substantial way with their pain, I may have helped them with their worst problem. It's just such a high impact condition if you have significant amount of chronic pain.
Absolutely.
Very good. So I'm going to repost Dr. Kaufman's information in the comments here, so you know where to find her. Thank you so much for being here. One of our viewers says, I'm so happy you touched briefly on the topic of individuality in treating patients. Aw, that's right. And wouldn't it be boring if everybody was the same?
Yes.
I would be.
And that's one of the things. Right. And that's one of the things I love about my job, is that I see babies all the way, and patients of all ages all the way up through our elderly population, for all different types of problems. And every patient is different, and every day is different. And it's just so much fun to be able to help the community.
Thank you. Well, thank you, viewers on live. Thank you, viewers in replay. This is so good. If this episode's been helpful to you, please consider sharing it with a friend. Work together with your people to improve your health. At Livestream, we'd love for you to subscribe to our YouTube channel or like our Facebook page, and tell us what you want to see. What content do you want to see? What more do you want to hear about? I would love to provide those interviews and discussion. And if you or someone you know is looking for a pain management physician in Maryland or in the Mid-Atlantic, we would love to help you overcome pain challenges so you can live life better. Call us at Livestream Health. You can learn more about us at livestreamhealth.com. Thanks.